Bismillahirrahmanirrahim. I would like to start by thanking the entire team of Saifee Burhani Medical Association of North America for this opportunity. It's really an honor to be a part of this conference. I'm going to discuss the effects of smoking and alcohol from a rheumatological point of view. Smoking and alcohol can have impact on many rheumatological diseases, but for the sake of time, I'm going to focus or concentrate on few significant diseases: rheumatoid arthritis, lupus, which is commonly called systemic lupus erythematosus, Raynaud syndrome, and then finish my talk by discussing the effects of alcohol on gout. So let's talk about rheumatoid arthritis. It is the most common form of inflammatory arthritis, in contrast to osteoarthritis, which is a non-inflammatory arthritis. It affects about 1% of the adult population, and US approximately about 1.3 million adults suffer from rheumatoid arthritis. They most commonly present with significant morning stiffness, and this is the differentiating point if they have rheumatoid inflammatory arthritis or non-inflammatory arthritis. Because in patients who have rheumatoid or other inflammatory arthritis, the morning stiffness can last for a couple of hours. Joint pain, joint swelling, and it can also involve other organs in addition to joint. Most commonly includes eyes, lung, skin, but it can also involve major organ like heart, kidney, and brain even. Now, it's very important to diagnose rheumatoid arthritis early and treat, because the joint damage which happens from these arthritis, it can be permanent. And this is an example of one of the neglected case of rheumatoid arthritis. You can see the damage of many joints of the hands, and even whatever we do at this stage, it's gonna be irreversible. So in order to understand how smoking affects the rheumatoid arthritis, it's very important to understand the mechanism of rheumatoid arthritis. It's not as simple as we think. There are many factors involved: genetics, environmental, immunological, and other factors. And this is a diagram which will simplify some of the factors which are involved in pathogenesis. So in this one here, you can see this is a normal joint, and this is, in contrast, rheumatoid arthritis joint. A lot of inflammatory cells are present, and a lot of damage is going on in the joint. Now, if someone has genes which are predisposing to rheumatoid arthritis, and in addition, they get a second environmental hit, we're going to discuss smoking in this factor, then this leads to the modification of the protein, which in turn activates inflammatory cells, and they can produce inflammatory enzymes and cytokines, which will go to the joint and cause a direct hit to the joint. Now, the second mechanism is these cells can go to the antigen-presenting organs like lymph nodes and spleen, which can activate many of the inflammatory cells, and then these cells can migrate to joint, leading to the second damage of the joint. Now, obviously, we cannot control the genes. It's the way we were born by nature. But we can always control the environmental factors. So if someone has genes and they do not get a second environmental hit, they may not develop the rheumatoid arthritis. So it's very important to avoid those factors so you cannot get this disabling disease. Now, what is the evidence? There's a lot of studies in last several years which shows that there is definitely a link between rheumatoid arthritis and smoking, and also how aggressive the rheumatoid arthritis can progress if patients smoke, in contrast to non-smoking group. I just put some of the studies here. I'm not going to go in detail of it, but each of the studies showed there was a direct link to the exposure of smoking and the development of rheumatoid arthritis. Now, this is a chart which is showing how smoking can lead to the development of rheumatoid arthritis. So in cigarette the main harmful component is nicotine. But in addition to nicotine, there are many other harmful ingredients which we grouped into polycyclic hydrocarbons. Now, they lead to the damage of the cells, and then those cells produce all these inflammatory cytokines, as I mentioned earlier, and then they can cause the acute inflammation, which, if persistent, can lead to chronic inflammation. Now, again, another important factor here is natural. By nature, we have an anti-inflammatory cytokine, which is called IL-10, and smoking decreases that anti-inflammatory cytokine, leads to increase in the inflammation in both ways. So how much is the risk? It has been proposed that the risk is about 20% in patients who smoke 1 to 10 per pack per year. And you can see the risk increases exponentially to 94% if they smoke 20 pack per year. And the way we define pack per year is there's a formula, how many number of cigarettes smoke per day divided by 20, and how many years they smoke. So it's very important to see it's not only how much you smoke, but also how many years, how long you have been smoking. Both of them are directly linked to the progression of rheumatoid arthritis. As I said, that intensity as well as the duration, both are important in the development of smoking, and it also continues, the risk continues even after the cessation of smoking. So the best thing is not even to start. And in children, the families who smoke, the children born to those families are exposed to secondhand smoke, the risk, they have a higher susceptibility to develop rheumatoid arthritis and other autoimmune disease. There was a study published, and they clearly saw that those children were more susceptible as compared to other families which do not smoke. So conclusion, there's a strong link between the rheumatoid arthritis and smoking. There's no doubt about it. In addition to causing the rheumatoid arthritis, there's also reduces the effectiveness of many rheumatoid arthritis medications, and it is not only the development and the progression of the arthritis, it also has much higher increased risk in the mortality. So patients who smoke and have rheumatoid arthritis, the mortality risk is double as compared to the patients who do not smoke and they had the rheumatoid arthritis. So now we're going to go to the second disease, which is called systemic lupus erythematosus. Commonly, it's called lupus. In contrast to rheumatoid arthritis, it can affect any organ of the body. It is, again, the chronic autoimmune disease of unknown etiology. It can affect any organ of the body, and it can range from mild joint and skin involvement to major life-threatening organ involvement. Now, this is a diagram which is showing what are the symptoms of lupus can be, and you can see it can affect any organ of the body. Most common symptoms include mouth ulcer, nasal ulcers, a butterfly rash, joint pain, rashes, hair loss, fatigue, but it can also involve the major organs like kidney. Lupus nephritis is a very significant organ which can get affected by lupus. We see mainly in females of reproductive age. In blood, it can involve any cell line, thrombocytopenia, leukopenia, anemia. In heart, any lining can get involved, myocarditis, endocarditis, pericarditis. And again, in lungs, it can manifest from pleuritis to pulmonary hemorrhage and to pulmonary emboli. So again, most of the disease in rheumatology, they have a complex etiology, and most of the time we don't know the exact etiology. But again, there are many mechanisms which can lead to development of lupus. Genetics, environmental, hormonal, and many other immune factors are involved. So again, this is a diagram showing how many factors, genetics, environmental, hormonal, other immune factors, can lead to the activation of immune cells, produces antibodies, immune complex, then lead to production of the cytokines, and they can damage multiple organs in the body. And in environmental, again, smoking is one of the main factors we have found that it can be linked to the development of lupus. There's another mechanism how smoking can affect, it increases the number, when the nicotine is inhaled, it increases the alveolar macrophages in the lung, which in turn produce some lysosomal enzyme and elastase, and then that can cause to parenchymal and connective tissue damage. So this is again a second mechanism how they explain smoking can lead to the progression of lupus. Patients who have lupus, in addition to causing lupus, if they have lupus nephritis, their kidneys are more likely to be affected as compared to non-smoking group. And one mechanism they thought is because smoking can lead to high blood pressure, which produces more strain to kidney. And in addition to, if the kidney is already involved from lupus, that's going to be a second hit. Again, the patients who have only cutaneous lupus, means they have rash and only the other skin involvement, they are more active in smokers as compared to non-smokers. Smoking also decreases the efficacy of some medications like in rheumatoid arthritis, anti-malarials, hydroxychloroquine, which is the most common medication we use to treat lupus. Now, the another disease is Raynaud's phenomena, and most of you already know what's Raynaud's phenomenon because many patients present to primary care and other specialty before they come to rheumatology. And Raynaud's, actually it's an exaggerated vascular response to either the cold stimuli or any stressful stimuli, and it can lead to sharply demarcated color changes of your body part, especially the fingertips and the toes, but it can also involve other organs of the body like nose, tip, ear, but they are less common. Usually by textbook, it has to have 3 phases, but as we know, patients don't read textbook, so they do not, when they come to the doctors, they usually do not describe these clinical characteristic 3 phases. Initial is a white, which is caused by vasoconstriction of the blood vessels. The second phase, which is the most dangerous phase, is the blue phase, the lack of the blood flow. And then the last one is your body realizes it, release mediators, and it's a rapid blood reflow and leads to the manifestation of bright red color of your fingers or toes. You can see in this diagram, all the 3 phases are occurring simultaneously. These 2 digits are white. From the first phase, you can see a slight bluish hue here, which is from the second phase, and then there's a rapid blood reflow on these areas, which is causing a bright red appearance. But this is a classic picture, but usually we do not see these demarcated 3 phases. They are always blend into each other. This is one of the more significant phase, and you can see there's one damage already happening here, an ulcer because of the continued decreased blood flow to the body. So usually we classify Raynaud's into two categories. Primary means they are completely normal patients, no underlying problem, and they just come, oh, I have this color changes, what's going on? Those, when we do all the workup, we do not find anything. Those patients are, we put in these categories as primary. They are more benign as compared to secondary, more easier to treat. The second form is like more dangerous category, I would say. It is secondary Raynaud's phenomena. Usually they have an underlying autoimmune disorder. It can be lupus, myositis, Sjogren, systemic sclerosis. It can be any hematological abnormalities like multiple myeloma, cryoglobulinemia, where there's increased vascularity, or some drugs like migraine medications, over-the-counter decongestant, or some chemotherapy drugs can also lead to the progression to the development of Raynaud's. So how does smoking affect Raynaud's? It's simple as compared to the previous rheumatoid arthritis and other disease which I discussed. Smoking causes the blood vessel spasm. And that's how the Raynaud's phenomenon happen, usually from poor circulation to the hands, feet, and other parts of the body. So if in addition to this, they smoke, it's gonna be a second hit to them, and it can lead to mild case to a more dangerous case, and even leading to the damage, permanent damage to fingers, toes, gangrene, which may require amputation. And you can see in this diagram, this is a very significant case. I mean, this is only limited to the fingertip, but it can involve the entire digit. And then which needs to be amputated. So the bottom line in the other three diseases is smoking can affect those, and it's very important to cut down or even completely stop the smoking to prevent the progression of those diseases. Now I'm going to shift my talk to alcohol, and we all know about gout, and there's no doubt about that alcohol has an impact on gout. It is a type of an inflammatory arthritis which is caused by deposition of monosodium urate crystals in joints most commonly and other areas of the body. And this mechanism is simple as compared to other disease, which is we don't know exact etiology. This is mainly a metabolic disease, mainly a diet-related issue, which can be easily controlled with lifestyle changes. It used to be called disease of kings because of its, in previous era, the kings and rich people, they were using the diet, but it's not as true as now especially in Western countries, even lower socioeconomic population, they can lead, the incidence of gout is rising because they have the same access to the diet and other factors which can lead to gout as compared to the higher socioeconomic population. So what are the symptoms? It's a very painful disease. It's often compared to as having a childbirth in female. It's very painful, redness, warmth, and the swelling of the affected joints. More frequently, patients walk in the clinic walking with crutches because of the significant pain in the joint. At least 80% of the first attack involves the lower single joint and mainly the lower extremities, and especially the first big toe, which we call podagra, and knee or foot or ankle, and then, but if it continues, if it's uncontrolled, it can involve any joint of the body, and it can also cases have been described in the spine too. Now, one characteristic feature to differentiate by looking at the patient, it is gout, that signs of inflammation extend beyond the joint. So it's usually, you can see, it can mimic cellulitis. Now, this is mainly an attack here in the first, but the signs of inflammation extending beyond the joint. So this can mimic cellulitis or a fracture, but this particularly patient has a gout attack. So what happens, how does uric acid has an influence, leads to development of gout? Either it can come from the diet or from the regular cell turnover. It leads to the production of xanthine, hypoxanthine, which will be metabolizing into uric acid. Now, 80% of the time it can get excreted from the kidneys, and normal, if the level rises above certain more than 4 to 6 milligrams is the normal level which body can handle. If the level rises above this, then body will not handle, and it will go and precipitate into different joints of the body, different parts of the body, especially the joint, but it can also go into the kidney. So now again, we cannot control the normal cellular turnover, which will lead to production of uric acid, but we can definitely control the diet and decrease the amount of uric acid, which can lead to deposition into other joints. And this is one of the diagram which is showing how the uric acid is precipitating in the joint and leading to intense inflammation, because joints are normally not supposed to handle the uric acid. They think it is a kind of foreign material. So when they get uric acid deposit, it produces an intense inflammatory response. Now, this is one of the chronic case of gout. You can see multiple yellowish deposits. These are all uric acid crystal deposits in the gout. It's going to be very hard to treat, and you can see all the deformities which can happen. Now, it must be going for a long, long time, and patients did not pay attention, and then they come to the practice at this stage. So what are the causes of gout? Let's talk about the diet. We know red meat, especially, that's one of, they call game meat because it's usually they have when there's some game tournament going on. Red meat, any red meat can lead to increased uric acid. Seafood, shellfish, crabs, lobster, small sardine fishes. Sometimes high fructose corn syrup, which is found in artificial juices, can increase the uric acid too. And our focus of interest is alcohol, and that's what we're going to discuss, but definitely alcohol has a great impact on the development of gout. So it has a significant dose-response relationship, how much the alcohol they consume and how much the recurrency of gout attack they will experience. And it's also important, it's a misconception that only beer or liquor can cause gout, but any alcohol beverage practically can cause gout, either it is wine, beer, or alcohol. Now, some of the alcohol beverages have a higher incidence to leading to development of gout, but in fact, any alcohol beverage can cause the development of gout. And it is also important, the second misconception among general population is that if they drink episodic, like let's say on the New Year or Christmas or something, then that will not affect their uric acid, which is not true. Episodic alcohol consumption is also linked to to increased level of recurrent gout attack. It also matters how much they consume during those New Year's or other holiday season. If they are making up for the whole year, then definitely that's gonna be the same as you consume daily. So the mechanism again is clearly crystal clear how alcohol can cause increased uric acid. It alcohol causes the increased liver breakdown of ATP, adenosine triphosphate enzyme, which breaks down to urate by your body. The second thing, as I mentioned, that some alcoholic beverages, especially beer and liquor, has a high purine content that will lead to increased risk of the gout attack. And the third one is not as common these days because it used to be in past. They used to make this characteristic alcoholic beverage moonshine in lead-tinted vessels. Now they don't use it because of chronic lead poisoning, and that used to cause gout because from the secondary kidney tubular damage. So conclusion, patients who have gout should limit alcohol of any type of all the types to prevent the risk of the recurrent gout attacks. So, well, I thank you for your time and concentration. And आखिर में दुआ करें खुदा ताला अपना मौला आली कदर मुफद्दल सैफुद्दीन उम्र शरीफ ने तारुज़े क़यामत दराज करे. And I'll be happy to take any questions at the end of the session.
Well, I think we can go ahead and do some questions now if you'd like. Dr. Shabnam, thank you. Excellent presentation. I'll be honest, we were trying to contemplate how a rheumatologist was going to talk about Moharramat. I couldn't figure out, but you did a fantastic job.
Thank you.
MashaAllah, subhanallah, alhamdulillah.
Thank you.
So I think, someone clapping? Sorry.
Thank you, everyone.
Dr. Idrisbai, go ahead. Can we have the bouncing mic, the throwable mic, the football mic? I want to take that home, by the way.
Thank you for your talk, much appreciated. So I'm from pulmonary medicine, so we have a little bit of a love-hate relationship with rheumatology.
Yes.
And rheumatoid arthritis in about 25% of patients with long-standing RA can cause pulmonary fibrosis. So what we have seen on the lung side is in certain interstitial lung diseases, if you quit smoking, the disease resolves itself and you come back to baseline. So certain interstitial lung diseases does that. What I want to know is, on the RA side, if they stop smoking, does that inflammatory response die down, or it is a genie that cannot be put back in the box?
No, it does, definitely, but it takes a long time. Now, patients, it's not like if they stop smoking, they're gonna have like next week or in a month, they will have a good response. It takes years to go back to the original, but I have seen clinically in my patients who stop smoking, they respond to medication much better as compared when they continue to smoke, and the risk development to other organs, like you mentioned, kidney and skin and other organs, I have seen much better response in those patients who quit smoking. So first thing when I see any patient or all of my colleagues, when they see patients with rheumatoid arthritis who is or active smoker, first thing we tell them that you cannot control the genes, you were born with that, but you can definitely control the second hit, and it does have a great impact on that.
And Is Plaquenil one of the drugs that get affected in this efficacy towards treatment?
Yes, that's the one we know the most documented we have. Now, Cellcept, which I'm sure you're aware, that also gets affected by smoking. We see decreased efficacy in those patients, but Plaquenil is one of the most common. In lupus and rheumatoid arthritis, the efficacy decreases much more with the smoking.
Thank you.
Sure, welcome. Okay, thank you again.
I do have a question. Oh, go ahead. Idris Bhai, throw him the mic. Literally, you can throw that one.
Okay.
No, I'm serious. You can throw it.
Oh, okay. There we go.
Shukran, Dr. Shabnam. I had a quick question. I know, rheumatology, it's not very clear cut. There's a lot of trial and error. And sometimes patients aren't what you see in the textbook. They kind of have a very gray area where they have combinations of this and that and that. And I know sometimes empirically we'll try like Plaquenil and things like that. Are you seeing a predisposition on the immunosuppression on patients like that, and then them abusing certain amount of drugs, causing certain infections and things like that?
So it's a very good question, and yes, in rheumatoid there's no clear cut. It's very overlap of everything, and that's what makes it interesting. But the immunosuppressive medication, they do not have any addictive or abusing potential other than prednisone, I would say. Because steroid, as we know generally, it boosts the energy level, right? So if I give even to any normal people, or I tell my patients if I give it to my nurse, she will be very happy. Yes, but other immunosuppressive, they do not have that abusing potential. Risk of infection, yes, it's the first on our top list. We see it all the time. And for me, as I have a background infectious disease, it's very easy for me to look over those things which will lead to. But in general, yes, all the immunosuppression except the Plaquenil, which is not an immunosuppressive medication, have the potential increased risk of infection. And now with newer and newer biologics, they work great. I mean, they are a significant development in rheumatoid arthritis patient. I mean, the picture I showed you, that was before we had all the drugs. So I see those patients. We cannot, give them back their joints, but now we hardly see those. But infection, it comes, with the cons that infection is a higher risk there.
Shukran.
So I have one last question for you. In your experience, do you feel that rheumatological diseases is a pathway to increasing the risk of abuse? And two, what tips can you provide for this initiative from an adult perspective that we can implement in programs for the future?
So basically, when the patient has pain, right, and most of the disease which we manage affecting arthritis is a pain. Pain changes the personality of the person. So they like to use anything. Now there is a big trend of using marijuana. And which is now, you can have a marijuana card. You don't have to see a certified rheumatologist or any other doctors. You can just get the marijuana card, and that they uses it. And they don't want to go to rheumatologists because it has abusing potential, it has addictive potential. And some of them who do not have a knowledge of how it can progress, they just keep using it, and then plus they smoke more, they drink more. So their concept is just they don't want to feel the pain. But that's not the solution. I tell them it's not the solution because you're just killing the pain, but the damage is continuing in your body. So they finally come when they see their fingers are turning away or their joints is damaged, and then they realize that what they were doing is not right. So yes, it's an awareness because we have to tell, if you have a pain, you go and see a doctor of that particular specialty and find out the permanent solution, not just try to use opioids, overuse of smoking, alcohol, marijuana, which can definitely surpass your pain for the short time, but not the long time. And then you will have some other problems, right? Smoking, you will get heart attacks, and I didn't put all the other factors, but there's a deleterious effect of smoking on other organs if you have an underlying autoimmune disease. Thank you, everyone, again, for listening and your concentration. I appreciate it.
Now I'd like to present Dr. Huzaifa by Saifee.
Mustafa Bhai, I had a follow-up question if there's time while Huzaifa Bhai is setting up. For Dr. Shabnam bin, hi. I know that rheumatology sometimes gets dumped on because especially Eastern culture, we don't want to say that we have a mental health problem like depression, anxiety. So we somaticize and we say, I have back pain and nothing helps. As a rheumatologist now practicing here, Damari, like what are your strategies when you're faced with, you're going to do your workup obviously, but when you can pinpoint that it's probably something more psychiatric or psychological going on, what is your strategy? And I'm asking because, as the survey told us, depression, stress, anxiety, these are the things that push people in general towards Moharramat. So what are some of the strategies that you employ apna practice for this?
Yeah, I think the big group of the population is fibromyalgia. I can give you a common example. Nobody likes, we like to, walk on the back door when we see those patients. But the main strategy I use is just to talk, spend time with them. And you're right, they want to hide everything and they say, oh, I have, rheumatoid arthritis, my family has it, that's what I have, I read on internet and this is what I have. And the first visit, they will not accept that they have fibromyalgia or no other rheumatological issue going on. Even they want to try all these immunosuppressive medications. And they get mad when you tell them because sometimes they inherit the diagnosis. So my approach is always talk to them. I never tell them on the first visit, oh, this is wrong, you do not have that, don't come to see me, or this is, you need to go to a different one. I said, okay, yes, definitely, we can walk, let's do that, let's do the workup. And then I talk, spend time and explain that you are in a good shape, that you have fibromyalgia in contrast, or back pain, chronic back pain in contrast to rheumatoid arthritis or lupus, which are more dangerous disease and can be, life-threatening. And majority of the patients take it very, very well when they get this point. Now again, you will have difficult patients, as all of you in your field, which do not get it, and which is just, as a physician, we have to deal with them. But I think, from medical school, we that you spend time with patient, talk to them, and that's what's worked for my field.
Hold, Fakrullah, well,
Okay.
On a one-on-one basis, or we'll take it at the end after Dr. Huzaifa's talk.
أعوذ بالله السميع العليم من الشيطان الرجيم بسم الله الرحمن الرحيم به وبوليه مدعي يستعين في جميع الأمور خدا تعالى سيدنا علي قدر مفضل صفي آقا عمر شريف ने तारुज़ा क़यामत दराज कर जो. My name is Huzaifa Saifee. I'm a periodontist from Los Angeles, and I want to give you an alert. This is a dental presentation, so for all you physicians, I apologize in advance. There's a lot of diagrams and pictures to follow along with. I'd like to talk today about the effects of Moharramat on the oral cavity. My objective in doing so is trying to get a understanding of the jismani effects of Moharramat. Apne ruhani nuksan to khabar che, magar jismani na andar on your oral cavity, what impacts Moharramat do play. And by no means that we're going to use a comprehensive list of Moharramat or conditions of the oral cavity, but try to get an understanding of where what these Moharramat are doing to us. पहला अपने रसूलानी हदीस शरीफा से बरकत लेने जिक्र करिए कि रसूला फरमावे छे कि नज़्ज़िफ़ू तरीक़ल कुरान के कुरान ना रास्ता ने साफ़ करो. तो सगला असहाब किराम ये रसूला ने अर्ज़ की कि कुरान नो रास्तो इतले सु तो रसूला फरमायो कि अफ़वाहकुम तमार सगला नो मुँह. तो रसूला connected the mouth with Quran Majid. Quran સાથે જોડું છે અને એનું તનઝીફ, એનું સફાઈનું અમલ ફરમાયું છે. તો સફાઈનું ફરમાન છે તો કુરાને પાકના તિલાવતના કરનાર હોય તો લાયક છે, બલકે એમ કહીએ કે ફરજ છે કે તનઝીફના અમલના પહેલાં આ મુહર્રમાતથી કુલ્લિયતન ઇજ્તનાબ, complete દૂર થવાની જરૂરત છે before we can even start the conversation about તનઝીફ, બલકે તનઝીફના અમલના અંદર શામિલ છે. So let's start by going through an overview of what we'll be talking about today. Again, this is no means an exhaustive list of all the conditions that are affected by Moharramat on the oral cavity, but we're trying to get an understanding of what Moharramat do to our oral health and also our systemic health to a certain extent. We'll go over a particular condition, then go a little into some statistics about those conditions and about how Moharramat directly impacts those particular diseases. First, we'll talk about cleft lip and palate, move on to periodontal disease, and then finally oral cancer. Next, we'll discuss just a little bit about vaping and understanding what vaping is, and understanding how to identify it and its harms and risks. Finally, अपने कलिमात नुरानिया से इस्तेनारत करीने थोड़ी जिक्र ने खुलासा करसूं. So the first condition I'd like to bring up today is cleft lip and palate. Cleft lip and palate are two distinct but associated developmental conditions that manifest in the womb during the first trimester of pregnancy. Cleft lip usually occurs when the frontal process fails to fuse with the maxillary process, ending up with either a bilateral cleft lip or a unilateral cleft lip. This usually occurs in about 8 to 10 weeks into development, and similarly, cleft palate is also characterized by the failing of fusion of the palatal shelves. The prevalence of this condition is about 1 out of every 1,600 births in the US, and some sources cite about 1 to 2,800 and in the US, and it requires the management of multidisciplinary surgical and non-surgical specialists from the early months into adulthood. In addition to major functional and aesthetic deformities, cleft lip and palate children often face difficulty feeding in early days because of the inability to suck. And speech is usually impeded in later age. Also, the dentition tends to be fairly severely compromised in these patients. And these deformities can even persist after surgical correction and will persist well into adulthood and childhood and adulthood. Alcohol consumption has a profound impact on cleft lip and palate. A particular study looked at maternal binge drinkers in the first trimester and compared them to non-drinkers and found that the odds ratio was 2.2 for cleft lip and 2.6 for cleft palate. To get an idea, odds ratio, it thinks about the relative, the risk of a condition happening. And this is also dose dependent. So with the increase of number of drinks consumed by the mother, we did see an increased risk of this happening. Jim pehla zikr tha ke maskara kathiruhu fa qaliluhu haram. Ganu chag malau toy to inu thoru bhi haram cha. So that kind of plays into the idea of dose dependence. Even a little bit nuksan kare cha. Similarly, smoking also has a pretty profound effect on the risk of cleft lip and palate. We see an increased odds ratio in smoking mothers in the first trimester of about 1.34 for cleft lip and about 1.22 for cleft palate. And again, these are dose dependent. With the increase of smoking, we see an increased risk of development of these conditions. Next, we'll move on to periodontal disease. And this is more close to my field of practice and a little bit more dear to my heart. This condition is an immune inflammatory response to a microbial dysbiosis that affects the hard and soft supporting structures of the tooth. In other words, it's a shift of normal bacteria of the mouth into bad bacteria. And it causes inflammation around the teeth, which causes the erosion of bone and gum tissue around the teeth. It's essentially chronic infection around the tooth that leads to chronic inflammation that eventually leads to tooth loss. This condition is oftentimes characterized by nothing. It's asymptomatic in its early stages. Patients won't even know they have it unless diagnosed by a practitioner. Later stages, we do see red and swollen gums, bad breath, bleeding gums, pain upon chewing, loose and sensitive teeth, recession, and changes to the bite and occlusion, the way that the jaws bite down to each other. And it isn't an uncommon disease either. Approximately half the population suffers from periodontal disease, of about which 70% are moderate cases and about 10 to 15 are either mild or severe. These statistics say through all populations. This is a kind of a picture from representing of the United States, but throughout pretty much the entire world, all populations, India, Sri Lanka, Pakistan, Bangladesh, subcontinents, about approximately the same. And in addition, periodontal disease is associated with a variety of systemic conditions, which we'll go through a little bit here. It's a very widely discussed topic about periodontal diseases relationship with a plethora of systemic conditions. And each of these topics deserves its own discussion, but we'll kind of start to get an understanding of how chronic inflammation in one area of the mouth affects other organs in the other areas and in other systems in other areas of the body. Let's make our way through the list a little bit. First, in cardiovascular disease, it's shown that periodontal pathogens are implicated in cardiovascular disease, including increased risk of myocardial infarction, hypertension, and carotid atherosclerosis. In diabetes, periodontal disease has a bidirectional relationship. As your diabetes gets worse, so does your glycemic control. Glycemic control is under control, and your periodontal disease is also under control. If you treat your periodontal disease, your blood sugar, your A1C comes down. These are all documented studies. Moreover, respiratory diseases, asthma and COPD have an increased risk with patients with periodontal disease. We see periodontal disease in pregnant women. We see an increased risk of preterm birth, low birth weight, and preeclampsia. Lastly, the main bacteria that's implicated in periodontal disease, P. gingivalis, release gingipans, and those are implicated in Alzheimer's diseases. A lot of good studies are coming out nowadays regarding that. And lastly, periodontal disease is associated with an increased risk of cancer. Now, first we'll talk about how alcohol impacts periodontal disease. Alcohol basically exacerbates periodontal disease's severity and symptoms and has a dose-dependent response correlating to the severity of the disease. In periodontitis patients who drink, we tend to see more inflammation and more tooth loss. And even in non-periodontitis patients, patients who aren't affected with periodontal disease, we do see worsening periodontal indices. And that means we see more plaque on the teeth, more inflammation around the gums, more deeper pocketing, something that maybe a lot of you have heard when gone to the dentist. And so it does have a profound impact on even healthy individuals in the oral cavity. Two proposed mechanisms of this condition are, number one, an increase in reactive oxygen species, which kind of throws a wrench into signaling pathways, and secondly, an impact on, direct impact on inflammatory pathways itself. And when we have both of these together, it does cause a profound impact on the way that our body responds to the bacterial insult or the dysbiosis. Next, let's talk about smoking and periodontal disease. Unequivocally, smoking is the number one independent modifiable risk factor for periodontal disease. And the funny thing is that we can replace the word periodontal disease with a lot of conditions that us practitioners treat, and it holds true. It's not unique to periodontal disease. एवी चीज़ से कि बेबे मुंह ने अने जिस्म ने बिगाड़ी ना के We saw earlier that the risk for periodontal disease is normally pretty high in the normal population. About 50% have it. But smokers, they're way, way more likely to contract this disease. I may have even, in fact, say that I don't think in my practice I've seen a smoker that doesn't have some degree of periodontal breakdown. And we do see an improvement in patients, in former smokers, and they have a reduced risk of contracting the disease. And indices do improve over time with quitters from smoking, for former smokers. And this just doesn't end with conventional cigarettes. Any type of combustible tobacco products, marijuana, hookah, cigars, we see similar impacts on periodontal disease in those patients as well. And again, I don't want to bog everybody down with the pathology, but I'll just kind of briefly go over the pathogenesis of what we're talking about. Smoking, basically our assumption is two pathways that affects periodontal disease. The first pathway is to promote pathogenesis of the subgingival biofilm. It shifts the biofilm from good bacteria to bad bacteria in the periodontal pockets, as well as increases the virulence of the bacteria. The other pathway, smoking has a direct effect on the immune response of our bodies. Again, remember, this is a condition that is a chronic infection and also a chronic inflammation, and smoking kind of plays into both aspects of periodontal disease. In addition, there's a plethora of changes in the oral cavity and systemically that we see with smokers, and that also has an impact on periodontal disease. We see changes in salivary makeup, we see changes in cytokines, inflammatory cytokines, TNF-alpha, PGE2, and MMPs. And we also see a decrease in the concentration of protective mechanisms in the gingival curvicular fluid. Finally, we'll talk a note about just periodontal conditions, necrotizing periodontal conditions. Finally, to cap off periodontal disease, we'll talk about necrotizing periodontal conditions. And a way to think about this is if periodontitis or periodontal disease is a chronic disease, this is the acute version of it. What we see in this, in necrotizing ulcerative periodontitis, is it's a much less common condition, but it has a very dramatic impact. We see necrosis of the marginal tissues as well as the alveolar bone around teeth. This is usually topic nu discussion है कि effects of the Moharramat on the oral cavity. अपने रसूलानी हदीसी शुरू की दी है कि नज़ीफ़ु तरीक़ अल-कुरान इमा अफ़वाहकुम तंज़ीफ़ न पहला Moharramat से इज्तनाब ज़रूरी है. तीन conditions हमारा में ज़िक्र करीसु: cleft lip and palate, periodontal disease and oral cancer, and Moharramat ino impact. Vaping na बारा में अने पची कलिमात नुरानिया सी अपने सिनार करीने खुलासो करसु. Cleft lip and palate ni zikr ki di. It's a very major physical deformity that takes place in the womb at 8 to 10 weeks of development. And alcohol na sabab si almost 2.2 to 2.6 times vadare no risk thai che. And jitnu vadare apne alcohol istemal thai che jama hoi che during pregnancy, the first trimester, to itnu vadare risk che. Image smoking na andar bhi ye risk che. 1.34 to 1.22 relative risk hoi che vadare for smokers in pregnancy. Next, gum disease ni zikr ki di. Gum disease na andar, it's essentially a chronic inflammation and chronic infection around the teeth. Jina sabab si tooth loss thai che. And ima bacterial infection bhi hoi che and a body response bhi hoi che ke jina sabab si teeth loss thai che. It's seen with red and swollen gums, bad breath, bleeding gums, pain upon chewing, loose and sensitive teeth, recession, and changes in the bite. 50% karta zyada population occurrence che a periodontal disease ni, and 10% are severe people with the disease. And gum disease is associated with a lot of systemic conditions, body na conditions aate. Jivare periodontal disease roye che, so we see more cardiovascular disease, more diabetes, more respiratory diseases, pregnancy and other complications, dementia and cancer na rates zyada hoy che. Have alcohol, how it affects periodontal disease is that periodontist, whoever has a periodontitis infection, the severity of the disease is worse. And the indices more plaque, more inflammation, more bleeding in the individuals who do not have periodontal disease. Ima pathway mechanisms, scientific mechanisms review ki tu. And then finally, the periodontal disease and the smoking relationship discuss kari raha hai. In andar apne baat ki di, it's the number one modifiable risk factor of periodontal disease, and baat ki di, zikr ki di ke periodontal disease ne replace kariya cardiovascular disease na saate, pulmonary disease na saate. This still holds true. This is a condition or a Moharramat evi cheez che ke apne muh ne ane jism ne aapko bigari na ke cha. Ima thodu the metabolic and pathology ni zikr ki di. And then finally, we're discussing necrotizing periodontal conditions. These are conditions that rot away the gum tissue and the bone around the teeth, and it's seen at an increased risk in smokers. Next, the final condition we're going to touch on is oral cancer. We'll call oral cancer the group of conditions that affect the tongue, mucosal lining of the cavity, and the lips. And it kind of includes the bucket of oral cancers as well as precancerous lesions like erythroplakia and leukoplakia. These cancers account for about 5% of all cancers, and they're the 12th most common cancer. However, they are the 8th most deadliest cancers. The 5-year survival rate of squamous cell carcinoma is about 85%, which reduces down to about 65% when we see lymph node metastasis. Oral cancer can present in a multitude of ways. We can see them as lip sores, we can see them as mouth sores, whitish or reddish patches in attached or unattached tissues in the oral cavity. We can see them as growths, lumps anywhere in the oral cavity. They will oftentimes have some degree of tenderness or pain, mouth pain, and difficulty in chewing and swallowing will also persist in oral cancer patients. Majority of oral cancers are, as mentioned before, are squamous cell carcinomas. They make up about 90% or more of oral cancers. And most commonly, the site of metastasis is the cervical lymph nodes. And to a much, much lesser extent, the second most common site is the lungs. In addition, we do see a variant of the squamous cell carcinoma called the verrucous carcinoma at about 5%. This one is invasive. It's a much slower growth than the squamous cell carcinoma and doesn't have a metastasis potential. We also have other cells and areas in the mouth that we do see lesions in as well. We'll briefly go over the pathology of alcohol and oral cancer and the impacts of oral cancer, and one very unique qualifying factor about this condition. We know from our previous discussion that reactive oxygen species and acetaldehydes do have an effect, and these are both very carcinogenic. Our body metabolizes the ethanol and creates these reactive species that have an impact on essentially cancer. What's unique about the oral cavity here is that you also have your normal flora of the mouth, and a lot of these normal flora, when alcohol is consumed, these bacteria also break down the ethanol into these reactive oxygen species. And studies have actually shown that by consuming even a single serving of alcohol, it can increase the level of these acetaldehydes and the concentration of these acetaldehydes and reactive oxygen species in the mouth to carcinogenic levels. So no amount of alcohol is safe in this with this. Ma askara kathiruhu faqaliluhu haram. Thoru bhi jisamne nuksan pahunchaave chhe, and it starts to cause cancer. So what happens in this is our body cells break down alcohol. And when it breaks down, it creates carcinogenic, cancer-causing metabolites. And those metabolites cause cancer. And the bacteria in our mouth do the same thing. They break down the alcohol into metabolites, into products that cause cancer. So the combination of both of them in the mouth increase the concentration of these cancer-causing agents to the level that it has a very profound effect on causing oral cancer. So even a little bit of alcohol has a more profound effect in causing cancer in the mouth relative to the rest of the body. And studies do verify this. Any amount of alcohol usage comes with an increased risk of squamous cell carcinoma in the oral cavity. Studies do show that 20% increase in the risk of squamous cell with a single beverage of alcohol per day. Now, when we couple this with smoking, the risk of oral cancer goes up tenfold. And the proposed mechanism for this action is that alcohol will add the permeability to our epithelial cells, allowing the tobacco penetration into those cells. And we won't get into the mechanism of that, but the risks are tremendously more with smoking. Finally, just a quick note on the mechanism of smoking and the cause of oral cancer. Same things as discussed before: reactive oxygen species, inhibition of immune function, and epigenetic alteration of epithelial cells, I mean changing the expression of genes of these cells. But very interestingly, and again, I won't go into a whole lot of detail of this, but it does also have a cooperation with certain viruses that also increase the risk of cancer with smoking. Next, we'll touch on smokeless tobacco and smokeless tobacco products. In the US, it's known as chewing tobacco or snuff. It's used by approximately 2% of the US population. And when we look at populations like India, this is as high as 30%. They are known by various names and products. Here we have a list of what's available in the subcontinent. India under alag-alag naamon se aave chhe. These all have a profound impact on our oral health as well. And some photographs to kind of depict how readily available these products tend to be and how cheap they are. Oral cancer, a very common finding in these patients is smokeless tobacco keratosis, which is prevalent in a lot of patients. We see up to 60% in snuff users. They present as white lesions in the mouth. They're kind of patchy, and they have this keratotic feel over them. And these are precancerous lesions. We are concerned about them. They do have a potential to transform into more dangerous lesions. Next, and finally, we'll talk about qat. Qat is and those of us who are unfamiliar with it, it's a flowering tree that's native to East and Southern Africa and Yemen. Users, they take this leaf, the raw leaf, and chew on it to release a chemical called cathonin, which causes a mild euphoria, loss of appetite, and stimulation. They'll usually consume these products for several hours a day, social sittings, and essentially place a wad of the product in their mouth for several hours on end. હવે બુરહાની મૌલાના મુફદ્દલ મૌલાની સાઈ જલીલા રહી છે કે યમનમાં ખાસતન હરાઝના ઇલાકાના અંદર કે આ બલાસી દૂર કરે, મુમનીને દૂર કરે અને આ જે અસલ છે એનો ઝડો છે એને ઉખાડવાના અંદર. ખુદા તાલા આપની ઉમ્મીદોને તમામ કરજો, અમને યારી આપજો, તોફીક આપજો કે આ મુહર્રમાતથી કુલ્લિયતન અમને ઇજ્તનાબ કરવું તોફીક થાય. US under, this is a banned product. Qat is not available in the US, but it is endemic to places like Yemen. And the users of qat, whether short-term or long-term, it has an increased risk of... It's illegal. And it does have a higher incidence of squamous cell carcinoma. Now finally, let's have a brief discussion on vaping. I'll take a few minutes for that. Data on oral cavity and vaping is limited. However, the dental community in the United States have a very, very strong stance on it. In 2020, they had a resolution essentially calling for the ban and sale of all vaping products in the US that are not prescription or specifically for tobacco cessation use. And our obligation doubles as healthcare providers and khair khwah mu'mineen, first, most and foremost, to understand what these products are and how it harms us. Electronic nicotine delivery system, or ENDS, come in various shapes or forms. They come in e-cigarettes or vaporizers, pens, flash drive-looking devices. The looks vary, but ultimately the designs are fairly uniform. They have a battery, a heating element, a cartridge where they put the juice in, and a mouthpiece where they inhale from. And it's without any shame that these companies market these products like candy. This is not a gummy bear. This is actually the vape juice that contains harmful products for this product. And these devices are designed to look like toys. But we know what exists in these juices. They have nicotine, heavy metals, other carcinogens that we know are harmful to our bodies, despite the data not being available at this time. What is also very alarming is that the FDA, as of 2023, has approved over 23 ENDS products, electronic nicotine devices. That means the FDA concluded that based off of data submitted by the manufacturers that these products are for the public benefit. The angle these companies approach this with is they say that these products are safer alternative to smoking, and they market them as a smoking cessation device. But clearly, we know that that's not true. No studies to date show that these devices actually help smoking cessation. And when it comes to the youth population, the gains we have made over time in smoking cessation, traditional tobacco smoking cessation, have been completely wiped away by the use of these vaping and e-cigarette devices. It's important to understand that almost 30% of high school students have either used or have been exposed to a vaping device. आखिर में आपने मुफद्दल मौलाना कलिमात नूरानी सी बरकत लेने इस्तिनारत करिए. आका मौला मुहर्रमात नबारामा जोश खाइने फरमावे छे कि तमे जे ज़बान सी या अली कहो या हुसैन कहो अने ज़बान पर हराम चीज़ आवे लानतनी चीज़ आवे खुदा सगलाने तौफीक आपजो हरगिज़ ना लेजो मुमिनीन तमे या अली या हुसैन कहो जो तंबाकूમાં શું થાય છે શું કામ આદત પડી જાય છે બાઝ વખત ફેશન આદત બી હોય છે શું કામ આ ચક્કર આવે નહીં તો લઈ તો શું થશે મગર આજની ઘડી सी મૂકી દેજો તમે. ખુદા તાલા खैर ख्वाह मौला मुहर्रमत सी बचावनार मौला ने क़यामत लग बाकी ने बाकी रखजो. અને हमने तौफीक आपजो कि आ मौलाना कलिमातना तुफेल ना अंदर as healthcare providers खुदा हमने यारी आपे कि बिजा मुमिनीन ने जे आ मुहर्रमात ना अंदर फंसाई गया हो इन्हें निकाल मानी हमने मदद आपे आखिर ना अंदर we'll just talk about a few key takeaways and conclude our talk today. Moharramat cause oral pathology. That's very clear from the evidence that we see. And even a small amount of Moharramat does increase the risk and severity of oral conditions. No amount of Moharramat is safe. We understand that from data, the science has proven that. And apne khabar achhe. Maskara kathiruhu fa qaliluhu haram. And finally, what we also understand from the data is that cessation of Moharramat in time does lower the risk and severity of oral conditions. And Maulana Kalimat or Maulana Farmaan ni roshni na andar ke आज घड़ी ना अंदर आज घड़ी नहीं अंदर सी मुकी दे जो एंड खुदा ताला अगेन हमने यारी तौफीक आपे कि हमने बिजा मुमिनीन ने मदद करे आज चीज़ सी मुहर्रमात से निकलवाना है अल्हम्दुलिल्लाह रब्बिल आलमीन
CBD sab is a marijuana je oil nikale છે અને એનાથી પછી they make lotions, creams. કેમ કે CBD નું જે it has આપણે જે medical terms માં analgesia ઇસ્તેમાલ pain reducing properties છે એના અંદર અને એના અંદર એક THC એક molecule છે જે THC જે marijuana ના અંદર છે that's the addictive portion કે જે એનું અસર brain ને અને જે આપણે it lowers drive and initiative. એને ક્લેમ કરે છે કે THC નિકાલીને કેનાબિસ ઓઇલ બનાવે છે પણ એને એકદમ બરાબર તપાસ કરવું પડે. Most products cannot be completely free of THC. તો પછી એ જ માનામાં આવ્યું કે જે થોડું બી હોય એને ઘણું અમાઉન્ટમાં જોઈએ પણ એ થોડું બી હોય તો શાયદ એક પ્રોડક્ટ દેખવું પડે સાહેબ. But CBD is the oil from the cannabis plant, and એનાથી લઈને આ બધા oils and lotions બનાવે છે. લેબ એના ingredients પર લખેલું હોય અને ટેસ્ટિંગ કરાવે છે પણ એ ટેસ્ટિંગ કરાવવાથી એ લોકો જે પબ્લિશ કરે છે એના ઉપર દેખવું. ઘણીવાર શું છે કે લોના અંડર શું હોય છે કે 0.01% હોય તો they are allowed to say THC free by law, but doesn't mean કે 100% free છે કે 0.0% 1% બી હોઈ શકે છે અને એહતિયાત લાઝમ છે. જી સર. Any questions? We'll take 30 seconds to 1 minute for any questions for this. Box mic, 0 minutes. Bolo. So the question, if I got it correct, was that koi patient ne pain hoy and they need a narcotic medication.
Right. Movement patient.
Movement patient, you know, a morphine or something or some
Right.
sort, and you have to treat it with that.
Right.
ऐसा में तो रसूलुल्लाह ની શરીયત વસચ. There's ઘણી ચીજો એમ હોય કે બીમારીમાં હોય તો એને કોઈ બીજો તરીકો ના હોય તો એને ઇસ્તેમાલ કરવું એમ ઇજાઝત થાય છે. પણ એ you have to do your due diligence. If you're treating something that needs to be treated and there's no other means to treat it, એમાં વસત હોય છે. એના મુસ્તરીર તો મિલે यानी
શરીયત ઘણી સમહા છે. એવો વખત આવે ને એમ ફિકર હોય કે હવે મોત આવી જશે, જો નહીં કરું આમ હમણાં જમે આ ચીજ નહીં ખાવ હમણાં તો મોત જ આવી જશે મને. તો તે વખત જિંદા રહેવું જ્યાદા જિંદા રહીને પછી ઇબાદત કરવાની છે ને બરાબર છે ગુનાહ તો થાય એ ગુનાહ તો કહેવાય મગર કેવા ગુનાહ કે તે વખત મશફૂન બિલ ઇસ્તિગફાર પછી આપણે ઇસ્તિગફાર નથી માફ થઈ તોબા કરવાથી પછી માફ થઈ જાય છે એમના બી ઘણી ચીજોના અંદર પાણી નહીં હોય તો એમને કે પાણી નથી તો નમાઝ ના પડે તેમ ઉમથી નમાઝ પડે આમ બીમાર હોય તો નહીં અરકાન અદા નહીં થતા તો સૂઈને બી નમાઝ પડે ડૂબતો હોય તે વખત બી ઇશારાથી બી નમાઝ તો પડે આમ કરે આમ નહીં તો આમ નહીં તો આમ એમ નહીં કે આમ જ ઇબાદત કરવી છે તેથી અહીંયા જિંદાર નહીં રહે તો પછી ઇબાદત કેમ થાય તે વખત એવા વખત હોય તો હવે એ ખુદ તે વખત ડિસાઇડ કરે અને તેને એના જહેનમાં કે આ વખત એમ નહીં કે ચાલો લાઇટલી લઈ લીધું જેમ એમના કંઈ શરમ સબબ કરી દીધું એમ નહીં કે એમના પાર્ટીમાં ગયા અને જો મેં નહીં પીવું આ વખત તો બધા દોસ્તો મને શું કહેશે તો શરાબ પી ના એના અંદર તકિયત નહીં કંઈ એમાં તકિયત નહીં
Do we have time for one more question? Or two?
I think we have to call it.
Okay.
If you do have a question, though, you can please approach the individual speaker, and they will hopefully answer it. Right, Huzaifa?